Thank you very much. Good evening, everybody. Actually, I have chosen two topics. One is epistaxis, another is sinusitis. These two topics are very important for your MBBS exam as well as postgraduate exam as well. So, the first half is epistaxis and second half is sinusitis. Let us start with epistaxis. Actually, we know what is epistaxis and what are the study material today. In epistaxis, we usually ask questions in your oral exam, in your written paper. Sometimes we ask questions in a clinical problem-solving questions. We put one problem-solving questions linked with the epistaxis. So you have to answer that. So this is actually the whole discussion will be very much exam-oriented, not a theoretical discussion that much. I love just talking about the important parts of the examination. So it's not extensive, not that much difficult. Very simple way, okay? Now, so first thing is definition. What does it mean actually, epistaxis? Then what is epistaxis? We put this question in the exam, oral exam as well as your written paper. And management of epistaxis. How do we manage a patient with epistaxis? Suppose a 60 or 70 years old male patient, a hypertensive patient presents with epistaxis. How do we manage? This is a common question asked in the exam. And also other clinical problem solving questions. Definition of epistaxis, as you know, any bleeding from the nose is called epistaxis. That means for any reason, if there is any blood shedding through the nose or back of the nose, even through the mouth, that means from the back of the nose, from the mouth, this is also epistaxis. Not only that, the blood will come enterally, it can go back and come out as a spitted blood. So that is also epistaxis. But literally means bleeding from the nose is called epistaxis. Now, this is a very common problem. About 50 to 60% of the population in their whole lifetime may experience some sorts of epistaxis 1 or 2 times. And it's very common in children, as well as it is very common in elderly hypertensive patients. So these are two groups actually. One is children, another is aged patient with hypertension or with comorbidity, with other diseases. They may have this experience of epistaxis. Most of the epistaxis doesn't put you in risk. Very little, like 1%, 2% patients may have a very serious risk of epistaxis due to blood loss. Otherwise, most of the cases is controlled very nicely. Now, just this is actually the sites of bleeding. As you know, the intra-ethmoid artery is coming up, the post-ethmoid artery, spinopalatine, greater palatine, and your supralabial, all branches forming a plexus here is called Caesadex plexus at Little's area, and that is the commonest site of epistaxis. But we may have epistaxis in the back of the nose. This is the stenopalatine artery. From here, there is one plexus, is called Woodruff plexus. There is a posterior site of epistaxis. Sometimes the bleeding may coming from here, on the posterior artery. So that means on the turbinate, middle turbinate, upper half and lower half, or upper surface and lower surface of the area of the middle turbinate, that may be a site of epistaxis. So epistaxis may be anterior, may be posterior. So this is the mostly anterior side of epistaxis and the posterior side of epistaxis. But which is most dangerous? The anterior epistaxis, as we can easily see, so we can control epistaxis very nicely, but posterior epistaxis sometimes cannot see the bleeding point. So patient have serious loss of blood, and that may be endanger the patient's life. So posterior epistaxis is much more dangerous than the anterior epistaxis. But fortunately, most of the cases are anterior epistaxis, so we can control. Now, next is question is cause of epistaxis. This is the question asked in the exam, in short essay question paper as well as in oral exam. Now, we divide epistaxis into two groups. One is local cause, another is general cause. Under local cause means the cause in the nose, and general cause means due to general condition of the patients. So under local cause, mostly is idiopathic. That means we do know the etiology of epistaxis, mostly idiopathic, about 85% cases, idiopathic. Next is trauma. Just give a blow to the nose, start bleeding. So trauma may be your sports injury, maybe assault, maybe road traffic accident, any sort of trauma, or maybe foreign body in the nose or nose picking. Now, most of the children, they have a habit of nose picking and causes bleeding. Here in the nose, the retrocolumnar vein is there here, and that tear up causes bleeding. So this is the common in children is retrocolumnar vein injury. Uh, infective maybe rhinosinusitis or rhinitis. Inflammatory, as you know, chronic rhinosinusitis is inflammatory condition or infective condition. Person may have your Wegener's granulomatosis, person may have tuberculosis, person may have syphilis. They all causes bleeding. Neoplastic condition of the nose or any tumor or polypart-like lesion, like your rhinosporosis is a fungal disease, fungal granuloma that causes epistaxis. Your juvenile nasopharyngeal angiofibroma is a vascular tumor in the nose that causes epistaxis. Your Ringer's papilloma, your sinonasal cancer that can cause epistaxis. Okay, so this is the common local cause of epistaxis. General cause of epistaxis, as you know, patient may have hypertension, raised blood pressure, patient may have some hormonal like pregnancy is one of the commonest cause of epistaxis is hyperdynamic circulation. Pregnancy is important cause. Some drugs, it is also important cause of epistaxis, like the patient those who are taking aspirin, taking warfarin or anticoagulant drugs, they can cause epistaxis. Patient may have bleeding or protein deficiency like coagulopathy, factor 7, 8, 9 deficiency. Patient may have low platelet count. This is very common. It's called thrombocytopenia. And thrombocytopenia can be idiopathic thrombocytopenia, porphyria ITP. Patient may have a thrombocytopenia from any region. Like your classical cause nowadays in Dhaka city or Bangladesh is dengue. Dengue causes low platelet count. That causes epistaxis. High altitude, hormonal, all this. So these are general causes of epistaxis and local causes. Under local cause, idiopathic is the most important cause of epistaxis. Now, the question is this next question in the exam. Suppose a patient has come with epistaxis. How to manage? Suppose a 60 or 70 years old patient coming with epistaxis, how to manage? So the management of epistaxis, you write down in a very simple way. One is sort of quick assessment of the patient, either patient is stable or not. Patient already may lose lots of blood. So patient may brought to you with some attendant, and patient is in shock. So that is one issue. Another is patient stable. He or she is bleeding, no problem, but patient is talking to you, stable. So that is another scenario. So first thing is quick assessment of the patient. If patient is stable, and take a quick history. Either patient has got any trauma or taking any drugs, the blood pressure is raised or hypertensive patient. So this is very quick. And then just quickly assess the patient, and you can send blood for coagulation screen, send blood for group plasma, and then you try to stop the bleeding. So in this regard, first thing is quick assessment. Either taking history as well as drug history, hypertension, and quickly take a blood for coagulation screen as well as for your group plasma, and then do steps to prevent bleeding. Now, what are the steps of stopping blood loss or epistaxis? We usually say step-wise management. The first thing is DP. DP means you can write down this. This is the scenario of management of epistaxis. Any question in the exam. So this is your short notes. And then you write few words in under each heading. Okay. One is quick assessment, and then your DP. DP means digital pressure, Totter's method, this one. Then next step is Cautery, next AN spec, next PN spec, and surgical. So we'll go step by step. Now, digital diagnostic evaluation, I said history, all this, and then first set is, as I said, digital pressure. You press the enter part of the septum, because this is the site of epistaxis most commonly, and then put the ice pack over here, and you can suck some ice cube. And most of the cases, many cases, bleeding will stop. So this is first aid management is Totter's method, digital pressure. Number one step. Number two step is this. Look how we are doing. So this is a DP or digital pressure. Number two, if it fails to control bleeding, then have a look with the nose. If any clot, clean the clot or suck it out and try to find out the bleeding point. Try to find the bleeding point. If you see the bleeding point, then we have very easy method. You can cauterize the bleeding point at the end part with your silver nitrate stick. This is the silver nitrate stick. This is the silver nitrate stick, so we can use this one, or you can have a bipolar diathermy. Very easy way to give some spray, local anesthetic spray to anesthetize the face, nose, and then with the application of bipolar diathermy or the silver nitrate cautery, you can do this cautery. So this is called chemical cautery by silver nitrate or electrocautery by bipolar diathermy. So, and then if bleeding stops, put some naceptin cream or nasal cream and leave him go home. Let him go home, no problem, if his bleeding stops. But if the cautery fails or he cannot find the bleeding point, diffuse bleeding is coming up, the next step, third step is your packing. Intranasal pack. So the next third step is intranasal pack. Now the question we ask in the exam, what are the things, what are the materials we use for intranasal packing? And these are the materials. Classically, in Bangladesh, we use ribbon gauze, long ribbon gauze, soaked with Vaseline or antibiotic ointment. That is one. Number two available is your bib pack, bismuth iodoform paraffin paste pack. Nowadays, the Merocel pack is available. This is very sponge-like. We have this. This is the ribbon gauze. This is the intranasal packing. Classically, we put this one, ribbon gauze, with Vaseline or antibiotic ointment. We put layer by layer, and that usually stops bleeding. We have also, these are sponge-like Merocel pack. We don't need a ribbon gauze. Straight away put this nasal pack, and then inside the nasal cavity, once get in toss with water, it swell up and fit it in the nasal cavity very nicely and compress the bleeding vessels. So this is Merocel pack. We have also big pack. We have Caltostat pack, like your white hair, like calcium alginate, Caltostat pack. So these are the common intranasal pack. So you put pack, bleeding stops. Alhamdulillah, bleeding stops. So you put the patient in hospital, because you cannot let the patient go home with intranasal pack. The patient can, slip down to the throat. Patient have lots of problems. So, and then put an antibiotic, painkiller, and then keep the pack for 48 hours and then remove. So this is your third step of stopping bleeding. That you give intrapack, bleeding stops. Alhamdulillah. Now, fourth step is, if still you have given intranasal pack but still bleeding, or bleeding is in the posterior part of the nasal cavity. So in this situation, you have to put PNS pack, and then after putting PNS pack, again put ANS pack and keep the patient in hospital. So the next step is PNS pack or posternasal pack. Now, posternasal pack, we put this question in the exam. What are the easiest way to put PNS pack? In hospital, we have triangular shaped gauze piece with 3 thread. We put nasal catheter from nasal cavity to oral cavity, put it out, and then passing from one here and then take it out and then tie up with the thread and then pull this one and push the pack or the oral cavity towards the nasopharynx. This is very clumsy and very, time consuming. Sometimes patient cannot allow this one. Patient needs anesthesia. So that's to avoid this one. Classical, we have Foley's catheter. Very simple Foley's catheter to put PNS pack. So if I say, which is the best method of putting PNS pack? And the answer is Foley's catheter. Just take the Foley's catheter and put it through the nose to the oral cavity, inflate the balloon and pull it out. So the balloon will impact in the posterior corner. One side and then put another side. Khalas. Very simple. And once you put PNS pack and then put ANS pack and then keep the patient in hospital with antibiotic. And after 2 days later, you can take the ANS and PNS pack. So that is the PNS pack. Next step. Now, you are giving ANS pack You have given PNS back, still bleeding. Then what to do? This is a very rare situation. Most of the cases, bleeding stops with the nasal cautery or with ANS pack. Hardly few patients needs PNS pack. Extremely rarely, patient may not control with ANS and PNS pack. Then you have to go for surgical options. So there are some surgical options. So these are the different types of PNS pack, as I discussed. Follis catheter or 3-thread gauze piece. This is the classical device, the Follis catheter for PNS pack. Never forget this one, Follis catheter for PNS pack. Now, by this time also, if the patient has got hypertension, you have to treat the hypertension, any other lesion, any tumor, anything, then you have to treat accordingly. Now, surgical management, if you fail to control bleeding with the anterior and posterior nasal packing, or all measures fail, then you have to go for endoscopic cautery. That means we put a telescope and we try to find out the bleeding point and we cauterize with the bifurcatomy. We can ligate the entry artery here by Howard incision. We can ligate the posterior artery. We can ligate the maxillary artery through Carl-Doyle-like approach, through here, Carl-Doyle-like approach. Or sometimes very septal spar, spiky spar causes bleeding, so we can go for septoplasty operation. So these are the surgical options for management of epistaxis. Now, so that is all about epistaxis in exam-oriented discussion, not in theoretical, not that much theoretical discussion. Just what to do in epistaxis, that is the thing. Patient has come, quick review, patient is stable, quick history, drug history, hypertensive history, send blood for group response and coagulation screen, and then give digital pressure. If fails, cautery. If fails, internal pack. If fails, PNS pack and ANS pack. That's it. If still fail, then go for surgical options. Khalas for epistaxis management. Now the question is, there are some clinical problem solving questions related to the epistaxis. Like a 3-year-old boy presents with blood-stained, foul-smelling nasal discharge or unilateral foul-smelling nasal discharge with epistaxis. What is your treatment or what is your diagnosis? So any patients, children with unilateral foul-smelling nasal discharge with bleeding, diagnosis foreign body in the nose, old foreign body in the nose until proved otherwise. Next question, a 13, 14 years old or 15 years old teenage boy, this is not girl, boy, teenage boy presents with recurrent epistaxis, nasal obstruction, mouth breathing sometimes, cheek swelling, or sometimes has with proptosis. So what is your diagnosis? So there's many clues. One is this is a boy, not girl. Number 2 clue, it is teenage boy with recurrent epistaxis. Okay, nasal obstruction. So only answer is juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma. And that's all about the other question, okay, how to investigate. We usually go for X-ray soft tissue nasopharyngeal lateral view or MRI scan. Usually classical is MRI scan, and your treatment is different treatment options of juvenile nasopharyngeal angiofibroma. Classically, we exercise this one with transpalatal approach for you undergraduate students. We have other approaches. We have embolization of the feeding vessels and then go for operation. In intractable cases, we can go for also radiotherapy. We can have also testosterone receptor blocker. So we'll discuss later. Now, another question, a 55 years old female patient or male patient presents with unilateral blood-stained nasal discharge, nasal obstruction, and cheek swelling, sometimes loose tooth, and proptosis. So, if the female patient or male patient, aged patient, presents with blood-stained nasal discharge, unilateral, okay, and swelling in the cheek, proptosis. So, what is the diagnosis? So, diagnosis, carcinoma of the maxillary antral, sinonasal malignancy, carcinoma of the maxillary antral. Okay. So, these are another questions linked with the epistaxis. Another patient with suppose a 45 years old male patient presents with epistaxis, recurrent epistaxis, by some crust from the nose, associated with hemoptysis and hematuria. So think of that. The patient has a multi-system disease, multi-system disease. One is epistaxis by some crust from the nose, hemoptysis, and hematuria. So this is a disease which is involving the upper respiratory tract, like a nasal cavity, will also affect the lungs, affect the kidney. So this is a classical case, is a Wegener's granulomatous or granuloma with polyangiitis. GPA, granuloma with polyangiitis or Wegener's granulomatous. So these are the clinical problem-solving questions linked with epistaxis, and that is very, very important for undergraduate as well as postgraduate students. We usually put this question in the DLO, MS, FCPS as well as MBBS. So that is all about epistaxis, very short, and that is the just gist point that you need to know about epistaxis. What is epistaxis? Size of epistaxis, anterior, posterior, classical cause of epistaxis, local cause, general cause, how to manage epistaxis, stepwise management, 1, 2, 3, 4, 5 colors. Okay. Next is, so that is all about epistaxis. Now, next, very important topics is a sinus infection. We call sinusitis. How to learn this one? We usually learn definition of sinusitis. We will learn classification of sinusitis. What are the causes of sinusitis? What is the pathophysiology? Why there is sinus infection? Why? What is the problem? Then the clinical presentation of sinusitis. That means how to understand that yes, patient might have sinusitis. How to investigate sinus infection. How to treat this one. And if you don't treat sinusitis, what are the complications? Is all gist point of sinusitis study material, and that is very important for your exam. Now, the first thing is all these are viva questions. These all are written questions. These are all the clinical problem solving questions as well. I'll discuss. I think I have enough time. The first thing is definition. Now, in old days, we said sinusitis, but now we are saying rhinosinusitis. Why is that? Most of the sinus infection are rhinogenic origin. That means the origin is in the nose. From the nose, sinus lining of the nasal mucosa, and then infection spread to the sinuses. That's why we are telling the term rhinosinusitis. As you know, we have paranasal sinuses, we have anterior group, we have posterior group. Now, so sinusitis generally means it's an infection or inflammation of the paranasal sinuses. This is sinusitis. What is sinusitis? Infection or inflammation of the nasal cavity and paranasal sinuses. So that is sinusitis. Very simple. Infection or inflammation of the sinus wall or paranasal sinuses is called sinusitis. An infection of the nasal cavity and paranasal sinuses is called rhinosinusitis. Nowadays, we are saying rhinosinusitis. Hardly we use now old term sinusitis, but still we have many old examiners, they still love sinusitis rather than rhinosinusitis. Sinusitis may be acute, maybe subacute, maybe chronic. How to classify sinusitis? Sinusitis can be classified into, in general sense, into acute sinusitis and chronic sinusitis. When you say acute, when you say chronic. Now this is a time marking, or when it is subacute. Usually, if the infection of the sinuses or nasal cavity persists for 4 weeks, say 7 days to 4 weeks, that means 1 week to 4 weeks, this is called acute sinusitis. Okay, this is very important. Duration of infection up to 4 weeks, it is acute sinusitis. If 4 to 12 weeks, this is subacute sinusitis. When is a chronic sinusitis? When infection persists for a long time, that means at least 12 weeks or more. 12 weeks or more, that is chronic sinusitis. The definition of acute sinusitis is acute inflammation of the paranasal sinus mucosa that lasts for less than 4 hours, 4 weeks. That means up to 4 weeks is called acute sinusitis. And this is the new definition of acute sinusitis, is a EPOS definition, EPOS, European paper on rhinosinusitis. It's a EPOS 2012, but this is for postgraduate. This is not for you. How to define acute sinusitis? So, acute rhinosinusitis, ARS or acute sinusitis is defined as is acute inflammation or infection, inflammation of the nasal mucosa and paranasal sinuses for at least 4 weeks. This is called acute sinusitis from any cause, for any reason. Okay. Now, they said, the EPO said that there are some criteria of sinusitis. They say that at least there are some major symptoms, at least 2 major symptoms out of 1 must be there, and associated with other minor symptoms. So this is very clumsy actually. This is very clumsy for you people. For you people, the definition of sinusitis is just inflammation or infection of the sinuses, nasal cavity, rhinosinusitis. If it is less than 4 weeks, up to 4 weeks, acute. If it is at least 12 weeks or more, chronic. Khalas. Okay. Chronic sinusitis or CRS, we are now saying chronic rhinosinusitis, CRS. Chronic sinusitis is defined as long-standing infection or inflammation of the nose and paranasal sinuses for at least 12 weeks. That is your definition for undergraduate, the upper one. And the lower one is for postgraduate. New definition. The inflammation of the nose and paranasal sinuses characterized by 2 or more symptoms, one of which must be nasal obstruction, nasal discharge, plus minus facial pain, plus minus anosmia or hyposmia, plus minus CT scan findings and endoscopic findings of the changes in sinuses. So this is the classical definition of chronic sinusitis nowadays for undergraduate, no, for postgraduate student. That means the patient. So for undergraduate, I would like to say a few words about sinusitis complaints or symptoms. What is? Number 1 is nasal obstruction, nasal blockage, or nasal congestion. Number 1. Okay, nasal obstruction, nasal blockage, or nasal congestion. Number 1. Number 2 is your nasal discharge. Number 2, nasal discharge. Either internal nasal discharge or posterior postnasal discharge or postnasal drip. And number 3, disturbance of smell. That means anosmia or hyposmia. These are 3 cardinal symptoms associated with temperature in acute rhinosinusitis. Temperature, high fever. And there are some other associated symptoms like facial pain, like headache, pressure symptoms, that means facial pain or facial pressure, headache, halitosis, some referred pain from sinus, referred pain to the ear, so referred pain. As maxillary sinuses, so there is pain in the dental pain. So these are all the associated features. If it's acute infection, inflammation for 4 weeks with temperature is acute. If chronic, the same things, but for long time, for 12 weeks or more. So that is very simple. These are the symptoms of sinus infection. Never forget 3 important symptoms. One is nasal blockage, another is nasal discharge, another is disturbance of smell. 3, associated with some facial pain, headache, all this. Now, how to define that this is maxillary sinusitis? How to define that this is frontal, or this is ethmoid, or this is sphenoid? So if you take a history, the pain, why is the pain? If the pain is or tenderness about this area, the cheek, this is, or dental pain, this is maxillary sinusitis. If they're stooping forward, patient's bending, getting more pain in sinusitis. Now, if the pain is in the forehead, here, this is frontal sinusitis. If the pain in between the eyeball, here, this is ethmoid sinusitis. If the pain is in the behind the ear, behind the eyes, that is retro-orbital pain, or pain at the top of the head. So this is sphenoid sinus infection. So these are the common. So from sides, you can guess something. Why is the sinus affected? Okay. So this is all about the signs and symptoms. As I said, these types of sinusitis is acute and chronic. This is for you people. You don't need open, close, 10 sinusitis isolated, because if one sinus is involved, it's isolated. If more than one involved, is 10 sinusitis. Now, next is what are the causes of sinusitis? Now, if you think of that, why the sinus is infected and which sinus is most infected? If I ask this question in the exam, now the big sinus is the maxillary sinus. Other sinuses are ethmoid sinus, frontal sinus, or sphenoid sinus. Think one point that the drainage of the sinuses depends on many factors. The maxillary sinuses, their opening is not in the bottom. Their opening is in the middle, in the above. So how do they drain the sinuses? With the ciliary activity. So as the drainage of the maxillary sinuses depends on ciliary activity, therefore is mostly, and also opening is in the narrow cleft in the osteometal complex. Very complicated. That's why the maxillary sinus get more infected than the other sinuses. Because the frontal sinus, the ethmoid sinus, the spinal sinus, they draining towards the gravity down. So they pull the drainage easily. So that's why they are less affected than the maxillary sinus. And this is the culprit. The maxillary sinus, next is your ethmoid, then frontal, then sphenoid. Okay. Now, what are the causes of sinusitis? There are two factors, main two factors. One is host factors and another is environmental factor. Host factor means the patient's own itself, patient's own problem, like genetic problem. Patient has got ciliary activities is depressed, like your ciliary motility problem, cardigan syndrome, you know. So they have more problem of this. Anatomical variation of the nose is very important cause of sinusitis. Anatomical variation. What are those? Like suppose a patient has got, okay, I'll just tell some picture, show some picture. Environmental factor, we have infection like bacteria, virus, fungus, we have trauma, after operation, we putting some pack, this also causes sinusitis. We dive underwater, diving underwater, swimming in an infected pond, there are fracture of the maxillary sinuses bones, dental infection that can easily spread to the sinuses. So sinusitis causes, the two important causes, one is host factors, another is environmental factor. I mean, the host factor is a genetic, is your anatomical problem, a medical problem like patient has got diabetes, immunocompromised patient has got nasal polyps. They can also prevent drainage of the sinuses. Okay, so now look at here. What are the anatomical factors that can cause sinusitis? Now look at this. Suppose this is sinuses, the maxillary sinuses. These are the ethmoid sinuses, and they drain here in the middle meatus. Now, this is the middle turbinate, and this is the middle turbinate. Look at that. There is some air in the middle turbinate. This is called concha bullosa. And that concha bullosa can expand the middle turbinate and block the osteometal complex here. And that can cause a retention of secretion. So, there is one important cause of sinusitis, anatomical problem. Number two is suppose this septum. If there is close septal spur to this side, projecting here, or from here to here, so high septal spur that can block the problem. Anatomical anomalies causes sinusitis. Another is turbinate. Look at this. This is the middle turbinate. Now the middle turbinate, sorry, this is the middle turbinate. The middle turbinate normally concavity is laterally, and convexity is towards the septum. So if it reverse, that means normal contour of the middle turbinate is convexity medially. But if in some situation convexity is medially and concavity laterally, that's called paradoxical turbinate, and that can block the ostium. So paradoxical turbinate can causes, or uncinate process is very big or thick uncinate process that can also block the osteometal complex, and there are some halar cells here that can also block the osteometal complex, and that can causes sinusitis. So this is the anatomical anomaly. Look at this septal spur blocking the osteometal complex. Okay. This is another one. Okay. Internet connection unstable.
Slow.
Okay. Now, pathophysiology of acute bacterial sinusitis. This is a question for postgraduate. That's not we ask. So what happened actually? If the osteometal complex blocked or sinus nasal cavity has got anomalies, the normal lining of the sinuses cannot drain. So then what happens? So due to the allergic rhinitis or edema or blockage of the osteometal complexes, so there is edema of the sinus wall in case of acute sinusitis. Then what happened? Due to the blockage of the osteometal complexes, So inside the ear, there is some hypoxia develops. That means that the aeration or oxygenation is depressed. So there is hypoxia, and that causes the ciliary activity is depressed, or loss of motility of the ciliary activities of the sinus wall. And there is inside the lining epithelium, there is goblet cell, and this secrete more and more mucus, and there is mucosal stasis, and then initially virus coming up, and then bacteria is coming up, and there is bacterial colonization within the secretion, stasis, and that causes the sinusitis with all the discharge, with the fluid inside the sinuses. So all about this is the pathology, that is the blockage of the lining of the epithelium. There is ciliary activity is depressed. There is mucosal stasis, bacterial colonization. Now, I think we discussed about the symptoms that I said that in case of sinusitis, there are major symptoms and minor symptoms. Major symptoms are, as I said, nasal blockage, nasal congestion, nasal obstruction, number one. Number two, nasal discharge, entro discharge or posterior discharge. Number three, disturbance of smell, anosmia or hyposmia. And number four, facial pain, pressure effects, temperature, headache, in case of acute temperature, in case of chronic no temperature. Okay, facial pain, headache, then cough, then sore throat, referred pain, there is no earache. So these are the symptoms of sinusitis. Now, if you examine the patients of sinusitis, what we get? Have a look at the nasal cavity, you'll get a very much congested nasal cavity, terminated is very much swollen, edematous lining mucosa. There may be a pus in the middle meatus. This is very important point of identifying sinusitis, pus in the middle meatus. And if you examine this one, if you just percuss this one, press this one, you'll get tenderness over the sinuses. And if you percuss, you'll get tenderness or pain in the teeth in case of maxillary sinusitis. So these are the signs of sinusitis. Look at this. This is a pus. Look at this pus in the middle meatus. Pus in the middle meatus. In case of acute sinusitis, or even in chronic sinusitis, you can also get some pus in the middle meatus. There is a very important sign of sinusitis, pus in the middle meatus. Now, next investigation. Now, what investigation you want to do for sinusitis? If you have a look to the nasal cavity and paranasal sinuses, then only two investigations we have in your hand. One is X-ray paranasal sinuses, X-ray paranasal sinuses, occipital mental view. Another is coronal CT scan of paranasal sinuses. Two investigations. One is X-ray paranasal sinuses, occipital mental view. Another is coronal CT scan of sinuses. Okay. So this is the X-ray paranasal sinuses of the occipital mental view, showing what? Look at this here. The air and fluid level in the left maxillary sinus. This is the features of acute sinusitis, is air and fluid level. Air and fluid level in acute sinusitis. Now look at this air and fluid level in the left maxillary sinuses. This is the nasal cavity. This is septum. This is the nasal cavity. This is the turbinate. This is the orbit, and these are the ethmoid ear cells. Look, other ear cells are normal. Right maxillary sinus normal, nasal cavity normal, ethmoid ear cells normal. So this is, so what is the diagnosis here? My diagnosis is left acute maxillary sinusitis. So how to read this X-ray? Suppose this is your OSP examination. So X-ray, paranasal sinuses, occipital mental view, showing air and fluid level or haziness in the left maxillary sinus in its lower half with air and fluid level. So these are very good finding. And other sinuses are normal. So my diagnosis is acute maxillary sinusitis on the left side, or left acute maxillary sinusitis. This is the CT scan of the sinuses. You can also see the hypertension area here in the left maxillary sinuses with air and fluid level. And this is the turbinate, very much edematous. And this is septum. Other maxillary sinus is normal. So this is also acute maxillary sinusitis, left-sided. Okay, CT scan. So never forget two investigations of sinusitis. One is X-ray paranasal sinuses, occipital mental view. Another is CT scan. So you diagnose your case. This is, we're talking about now acute maxillary sinusitis or acute sinusitis. How to treat any sinusitis, acute maxillary sinusitis or acute frontal or acute spinal sinusitis. Usually think of maxillary sinusitis. we give treatment under two headlines. One is medical treatment, and another is surgical treatment. First thing, we'll try medical treatment. If it improves, then okay, you don't need surgical treatment. But if you give medical treatment and patient does not respond to your medical treatment, then still have pain, temperature, nasal blockage, all these, we have to go for surgery. What are the medical treatment? Now, as you know, this infection, usually patient has got upper respiratory viral infection, adenovirus, rhinovirus, respiratory syncytial virus, they're coming up first, and then followed by all bacteria coming up, like your Streptococcus pneumoniae, Diplococcus pneumoniae, Escherichia coli, Haemophilus influenzae, all the bacteria coming up. So the first treatment is medical treatment. What are the antibiotics? First thing is antibiotic against the bacteria. Now, what antibiotic we usually prescribe for sinusitis? We can use many antibiotics. You can use coamoxicillin, amoxicillin with clavulanic acid, coamoxicillin. You can use ciprofloxacin, you can use levofloxacin, but you have to write down the dose and duration. Coamoxicillin, in case of adult, 625 milligram TDS, means one tablet TDS for 7 to 10 days. In ciprofloxacin, 500 milligram BD. Levofloxacin, 500 milligram single once daily for 10 days. So this is your antibiotic. In case of children, you can give syrup or low dose like 375 milligram. Number two is, as there is congestion, edematous lining of the mucosa, sinus opening is very narrow due to edema. To reduce edema, we give decongestant. We call nasal decongestant in the form of xylometazoline or oxymetazoline nasal drops for 7 to 10 days. We can use steroid nasal spray, metaspray or flunas spray, fluticasone or beclomethasone or mometasone nasal spray you can use. You can use also linked with allergy, so you can use antihistamine, any antihistamine, Montelukast group you can use, no problem. But you have to write down one antihistamine, anyone, levocetirizine, loratadine, anyone, or Montelukast. Okay, and then as the acute sinusitis patient have pain, temperature, so you get paracetamol or analgesics, you get hot compression. Most of the cases and patients improves with this medical treatment. And then once the patient treatment improves, that's okay. Now, if after giving about 2 weeks treatment, patients still have pain, temperature, discharge, post-nasal drip, then you have to go for surgical treatment. Surgical treatment of sinusitis is your in the form of, now what to do actually. In old days, we usually put, I think for surgical treatment, in addition with the chronic sinusitis we will discuss, it will be easier then because the same. Now, chronic sinusitis presentation we already discussed. Same things, only duration is 4 weeks in acute, and chronic duration is at least 4 weeks to more, 4 weeks and above. But symptoms are more or less same, we discussed. Investigation same. Now, how to differentiate acute and chronic sinusitis in investigation? That is very important question in the exam. In case of acute sinusitis, I said in extraperennial sinuses, you will get ER and fluid level. Now tell me, chronic. Look at this. So this is the X-ray, perennial sinuses, oxidomental view showing a haziness in the right maxillary sinus. Whole right maxillary sinus has haziness. There is also partial haziness in the left maxillary sinus. There is also edema of the carbonate on both sides. So my diagnosis is bilateral chronic maxillary sinusitis. Okay, another X-ray. This is X-ray perennial sinuses, oxidomental view showing haziness in the right maxillary sinus. Other sinuses are radiolucent or normal. So my diagnosis is right-sided chronic maxillary sinusitis. There is no air and fluid level. Okay. Next is X-ray perennial sinuses showing a haziness in the left maxillary sinus. So chronic maxillary sinusitis, left side. This is haziness on the both maxillary sinuses as well as the haziness in the frontal sinus. So my diagnosis is pansinusitis. This is actually coronal CT scan of perennial sinuses showing extensive hyperdense area or soft shadow in the both maxillary sinus as well as nasal cavity is full of soft shadow. So this is actually bilateral nasal polyps with sinusitis. This is another one, right maxillary sinus along the nasal cavity is full of with hyperdense area. So this soft tissue mass in the maxillary sinus as well as nasal cavity, and there is also septal deviation or this must push the septum on opposite side. So this is sinusal tumor, maybe endocrine polyp. Now, this is the classical findings of CT scan of chronic maxillary sinusitis, coronal CT scan of paranasal sinuses showing mucosal thickening. Look at this, mucosal thickening of the left maxillary sinus, mucosal thickening of the right maxillary sinus with some polypeptide chains here. There is mucosal thickening of the ethmoid ear cells with haziness or hyperdensity in the ethmoid ear cells, both sides. So this is a classical case of chronic maxillary sinusitis involving the both maxillary sinus and both ethmoid ear cells. The classical presentation of chronic rhinosinusitis involving many sinuses or parent sinuses. This is classical coronal CT scan of paranasal sinuses showing a mucosal thickening in the right maxillary sinuses. Look at this, but other sinuses are normal. So this is chronic maxillary sinusitis on the right side. Now the treatment, again, acute or chronic surgical, we're talking about medical treatment, same, antibiotic, nasal decongestion, steroid nasal spray, antihistamine, if the patient has got pain, painkiller. Khalas. What about the surgical treatment? That is the question. Now, any acute or chronic maxillary sinusitis, surgical treatment are more or less same, the same steps of treatment. Initially, in old days, we used to do antral washout. That means flushing the maxillary sinuses. We usually put a trocar and cannula. We anesthetize the patient nose, the inferior meatus actually, and then, or we spray, and then we just put a cannula like this. Through the inferior meatus here, through the inferior meatus, about 2.5 centimeter from the antral end, and the direction is towards the tragus of the same side here. And we try to break the bones inferior meatus, and then put the trocar and cannula, and then take the cannula out, and we connected the cannula, take the trocar out and connected the cannula with 50cc syringe or helium syringe and flush the sinuses. What happened? The water will irrigate the sinuses, and they coming out through the natural ostia in the middle meatus, and the fluid is coming out. So this is called antral washout. In old days, all ENT doctors, they used to do this one and earning lots of money, making their houses, big houses, cars, all these with this antral washout in old days. Actually, endoscopic sinus surgery, the new technology is endoscopic sinus surgery. We'll discuss this one. So this one first is antral washout. We can flush the sinuses, we can drain the pus, and then put on antibiotic, nasal decongestant, antihistamine, and painkiller. This is a classical treatment of surgical treatment of maxillary sinusitis or other sinusitis in old days. This is antral washout. Then other options, intranasal antrostomy. That means we put a whiteboard cannula in the inferior meatus, and we try to break segment of the bones so that there is a permanent opening of the inferior meatus, and the sinus can drain through the floor. That means through the gravity. So they doesn't need any mucociliary activity. Okay. Another is Caldolak operation, is a classical one. We usually throw here. This is called canine fossa. We enter into the maxillary sinuses through the Caldolak. Caldolak operation has got lots of indication. We put this question in the exam. Indication of Caldolak operation, complication of Caldolak operation, and lastly, endoscopic sinus surgery or FACE. Nowadays, in these all four surgical principles of treating the maxillary sinusitis, this is called chronic maxillary sinusitis, antral washout, intranasal antrostomy. Okay, Caldolak operation and endoscopic sinus surgery. So classically, nowadays we are doing, most of those cases we are doing FACE. I introduced FACE in long ago in Bangladesh when I came back from England. I started endoscopic sinus surgery. Also, Dr. Zohir Alamin in Baden. We are doing endoscopic sinus surgery first time in Bangladesh. And now I think many of the surgeons or most of the surgeons now doing endoscopic sinus surgery. Now, this is the oldest treatment of antral washout. Look at this. This is me actually in my younger age group when I was doing practice at Bogura. This is young FRCS, Professor Matin, but that time I was a doctor. Doing antral washout, I think he is a first or second base of Shaheed Medical College. He was assisting me. This is the hospital nurse. Antral washout. So we are puncturing the inferior meatus. This is question asked in the exam. Which meatus? Middle meatus or inferior meatus? Through the inferior meatus. Okay. And there's lots of complication of antral washout, like facial swelling, mispuncture, proptosis, all these. So that is a complication. And how long you will irrigate? Until the return fluid is clear. We have to irrigate until the return fluid is clear. This is another irrigation. This is the endoscopic sinus surgery in my early ages when I was doing the direct viewing without any television monitor. We are using a 0-degree telescope to the nasal cavity, and we have tried doing the endoscopic sinus surgery. Now we are using this one. We are using monitor. Look at this whole monitor. We are looking at the monitor, and we are doing endoscopic sinus surgery. We are opening the sinus opening. We can drain the pus. We can explore the maxillary or antrum. We can explore the ethmoid. We can explore the sphenoid. All sinus we can explore. We can take the disease from it. We can remove polyp or any mucosal thickening or any polyps. We can take it out through endoscopic sinus surgery. This is the first step of endoscopic surgery, the telescope view. This is the middle terminal. We displace it medially so that we can have a big with the lateral wall. This is the uncinate process. So we make an incision here, and we do uncinectomy. So in endoscopic sinus surgery, there is short notes about face or endoscopic surgery. We'll discuss in the polyp section. But anyway, so how we do uncinectomy, and then we enter into the maxillary sinus here in this area. We make a big opening in the maxillary sinus because maxillary middle matter antrostomy. And then once we remove this one, this is the uncinectomy. This is maxillary antrum. Now, after removing the uncinate process and maxillary antrostomy here, this is the bulla ethmoidalis, the enteroethmoid group of cells. So we can punch this bulla. We can do enteroethmoidectomy. Look at this. So this is the enteroethmoidectomy we are doing. And then in the posterior is the posterior ethmoid. This is ground lamella. We puncture this one and then put the posterior. We can go to the posterior ethmoid. Anyway, so this way, this endoscopic surgery, we can also put this frontal sinus. We can clear the sphenoid, anyone. But before that, we have to get a CT scan. We get an idea which sinus is involved. If you don't treat sinusitis, then what are the complications of sinus? So these are important complications we have put in the exam. The orbital complication like orbital cellulitis, orbital abscess, then osteomyelitis of the maxillary sinus or frontal bones. We have mucocele of the frontal sinus or ethmoid sinuses. We have locoregional complication like your pharyngitis, sinusitis, otitis media, or we have intracranial complication like your meningitis, brain abscess, or cavernous sinus thrombosis, very fatal complication from sinus infection. So the commonest complication of sinus infection is your orbital complication, orbital cellulitis. We have also frontoethmoid mucocele or mucocele, and rarely we have intracranial complication. That's why it has to be treated. I think very short, quick review of sinus infection. So what did you learn about sinusitis in 1 minute? This sinusitis or sinusitis is infection or inflammation of the sinus mucosa and nasal cavity mucosa. If it is up to 4 weeks, it's acute. More than 4 weeks is chronic. Classical symptoms of sinus infection is nasal blockage and nasal obstruction, your nasal discharge and disturbance of smell. Other complications like a pain, facial pain, referred pain, cough, pharyngitis, all this. Treatment of sinusitis is your medical treatment and surgical treatment. Medical treatment in the form of antibiotic, nasal decongestant, steroid nasal spray, antihistamine. And surgical treatment in the form of antral washout, cardiac operation, internal antrostomy, or endoscopic sinus surgery. But if I say only one surgical treatment of sinusitis, that is functional endoscopic sinus surgery or FACE. That is the classical treatment of surgical treatment of sinusitis. So thank you very much. I think just I covered epistaxis as well as sinus infection is a big one. But these are the all exam-oriented topics, how to answer in the exam. Like one last question about clinical problem solving question about sinusitis, like a 35 years old male patient presents with nasal discharge, nasal blockage, and pain in the cheek and dental pain. What is the diagnosis? So my diagnosis, left-sided chronic maxillary sinusitis. If it's acute, they said with temperature for 4 weeks, acute. If it's persistent, then chronic sinusitis. How to treat? How to investigate? X-ray panel sinuses, occipital view, or CT scan of the sinuses. Treatment is medical and surgical. That's it. Thank you very much for listening to me. I think next classes we'll discuss about allergic rhinitis, nasal polyps, and sinonodal tumors. A very quick review, because this is for your division classes. For exam-oriented topics, only what we ask in the exam, not in details. You don't need details. Thank you very much indeed. Thank you. Thank you, Genesis, for arranging this such a nice program. Genesis.